Moving ahead on those lines, we will be discussing sexually transmitted infections in adolescents. We'll be focusing on the adolescent age group. We all know 10 to 19 years. And we have seen that the late adolescent and the young adulthood is the phase when the STIs are actually increasing in this phase. So why are sexually transmitted infections more common in this age group? Normal adolescent psychosocial development encompasses a desire for autonomy, an increase in sexual exploration, and initiation of behaviors that may predispose them to risk, all of which increase adolescent vulnerability to STIs. Reproductive tract infections are the infections of genital tract, may or may not be sexually transmitted. And STIs, these are the infections that spread primarily through the sexual contact. So these both go hand in hand, but not all reproductive tract infections are sexually transmitted, and not all sexually transmitted infections are located in the reproductive tract. If we have to describe, the RTIs include three types of infection. The STDs, which may include chlamydia, gonorrhea, chancroid, syphilis, and HIV. Endogenous infections caused by the overgrowth of organisms normally present in the genital tract of the healthy woman, such as bacterial vaginosis and vulvovaginal candidiasis. And iatrogenic infections, which are associated with unsafe abortions and delivery. So between 2019 and 2020, the rates of genital gonorrhea have increased. As per the CDC, the rates of genital chlamydia have decreased, and the rates of primary and the secondary syphilis have decreased in the males but increased in the female adolescent. As per the Indian survey NFHS 5, which was done in 2019 to 21, 5% of the women and 2.1% of the men in this age group who ever had sexual intercourse self-reported the presence of STI in the last 12 months. And these figures rise up to 12.3 in females and 9.3 in males, while self-reporting the presence of an STI, genital discharge, sore, or ulcer in this population respectively. The sexually transmitted infections, if we have to see in the adolescent group, 1 in 20 adolescents contract an STI annually, excluding the HIV. So why is it so? Physiologically, they are predisposed due to the presence of greater cervical ectopy, which makes the cervix more susceptible to gonorrhea, chlamydia, and human papillomavirus. Repeated acquisition of STIs is common. As many as 40% of the annual incidence of chlamydial or gonococcal disease occurs in the adolescents previously infected with the causative organisms, and this proportion may be further increasing. And this repeated acquisition is a risk factor for subsequent development of HIV infection, which will be discussed in the second talk. There are specific concerns in the adolescents. Even if it makes us uncomfortable, the concerns about the privacy and confidentiality are important barriers to seeking medical care among adolescents with possible STIs. So if we see this slide, the reproductive tract infections on the one end, the other end of the spectrum being the STIs, the HIV, AIDS, the hepatitis B. But what is common in between is the syphilis, trichomoniasis, chlamydia, gonorrhea, HPV infection, herpes simplex, chancroid, and genital herpes. So we will be focusing on this spectrum today. Majority of the cases, do we need to screen all of them? Yes, if they are asymptomatic, but if the person is sexually active, we need to screen them. Any asymptomatic infection can be transmitted to sexual partners and may be associated with sequelae and lead to complications. So how often do we screen? As per the CDC, in a cisgender females aged less than 25 years, for genital chlamydia, we need to screen annually. For gonorrhea, annually. For HIV, at least once. Hepatitis B, at least once if the age is more than or equal to 18 years. And HCV, at least once if the age is more than or equal to 18 years. If the person is at increased risk, then the additional screening for syphilis and trichomoniasis should be done. The assessment should be comprehensive and we should be non-judgmental. The sexual exposures should not be assumed and the person should be dealt with utmost sensitivity. Endogenous vaginitis, rather than an STI or RTI, is the main cause of vaginal discharge among the adolescent females. And 85% of gonococcal infection in females still remains asymptomatic. However, there may be slight vulval itching, minor discharge, urethritis, or proctitis. Chlamydial trachomatis infection is asymptomatic in the majority. Symptoms that may occur in adolescents are either intermenstrual bleeding, postcoital bleeding, and an increase in the vaginal secretions. Presence of anogenital warts and molluscum contagiosum should be looked for during examination. Candida albicans is uncommon in this age group prior to puberty. If present, the adolescent may have a discharge, vulval itching, dyspareunia, perianal soreness, or a fissuring at the introitus. Attacks of Candida vulvitis may be cyclical in nature and they correspond to menstruation, and this has been seen in the practice. Bacterial vaginosis does not produce vulvitis, and the adolescent will not complain of itching or soreness. The signs of acquired syphilis in children present with small chancres or mucocutaneous moist lesions either in the vulva or anus. Presentation of syphilis is same in the adolescents as in the adults. Prevention is better than cure, the age-old saying. So why not prevent these diseases? First is to avoid intercourse at this age group. Second, we need to inform. The information regarding transmission, prevention, and testing for STIs is important, including HIV. All the adolescents and the young adults who have not previously received HPV vaccination, the hepatitis B during childhood, should be vaccinated. And we need to provide integrated sexuality education at the school level, at the college level. So what are the signs and the symptoms which can be seen in the females and the males? Will be unusual vaginal discharge, genital itching, abnormal or heavy vaginal bleeding, any dyspareunia, any lower abdominal pain, blisters or any ulcers on the genitals, anus, mouth or lips, any burning micturition, itching or tingling in the genital areas, any warts, any history of fever, body ache or muscle ache. Suppose a boy comes to a pediatrician, the urethral discharge, burning or pain during micturition, any itching in the genital area, any inguinal swelling, blisters or ulcers, itching in the genital areas or the tingling sensation, any warts or fever, body ache and muscle ache as in the opposite sex. So the tailored sexual history taking for adolescent clients, including age-appropriate language, confidentiality, considerations, and addressing concerns related to sexual development and experimentation is very important. On the examination front, we need to inspect, always see the staining of the underclothes, the vaginal and the urethral discharge, any exudative ulcers which might have discharge on the undergarments. In the inguinal region, see for any swelling, ulcer, lesions of fungal infections. Look for the lymph nodes if there is any enlargement, abrasions due to scratching because of the intense itching or the lesions on the inner aspect of thighs. In the pubic area, see for the matting of the hairs, which is possible in cases of discharge or periculosis or folliculitis. Labia majora and the minora needs to be inspected after separation with both the hands. Look for any ulcers, any Bartholin gland enlargement, any discharge, color of the discharge, how is the quantity of the discharge, curdy or thin at the introitus. See the urethral meters if there is any discharge over there. Perianal examination is very important. Sometimes she just has itching around the perianal area in cases of fungal infection. And believe me, antifungal treatment, it helps in these patients. Palpation of the inguinal region and the ulcer at any site. So if a patient comes to us with these complaints, or we see that there is any infection, there has been a traditional clinical approach. When the doctor used to interview the patient for the symptoms, they used to clinically examine, and based upon the clinical experience, they used to identify the signs and symptoms and treat accordingly. Then came the syndromic approach, interviewing the patients, clinically examining, and giving a syndromic approach to both the partners. If facilities are there, we can take a slide and we can take a sample for testing and referrals to laboratories for testing, and specific organism can be treated, which comes under the laboratory assisted approach. And we are dealing with both the syndromic and the laboratory assisted. Education of the patients for compliance and prevention, condom promotion, and notification and management of partners is important. So first is the vaginal discharge syndrome. In an abnormal discharge, it can be increased in amount. There can be a change in the color of the discharge against the normal pattern. It can be foul or unpleasant odor, change in the texture or consistency of the discharge, and it might be associated with irritation, itching, pain, or around vagina. So we'll be discussing the discharges, then the lower abdominal pain, and then the syphilis in brief. The most common causes of vaginal discharge syndrome are infection with Candida albicans, bacterial vaginosis, and Trichomonas vaginalis. Among the post-pubertal girls, Neisseria gonorrhoeae and Chlamydia trachomatis infect the endocervix rather than the vagina and can thus cause a cervical discharge, which may manifest as a vaginal discharge. This is very important. It is actually a cervical discharge which manifests as a vaginal discharge. So the causative organisms in this syndrome causing the vaginitis are the Trichomonas vaginalis causing trichomoniasis, as we all know, Candida albicans for candidiasis, and or infection with Gardnerella vaginalis, Mobiluncus species, and Mycoplasma hominis for bacterial vaginosis. In the cervicitis, as we discussed, Neisseria gonorrhoeae and Chlamydia trachomatis, also Trichomonas vaginalis and genital herpes can cause cervicitis. The clinical spectrum might include an abnormal discharge, itching, burning micturition, increased frequency of micturition, dyspareunia, any ulcer swelling on the vulva, maybe a lower backache or an abnormal vaginal delivery. So what is in the examination? In trichomoniasis, there is a greenish yellow frothy discharge along with a vulval erythema. A characteristic strawberry cervix can be seen. In candidiasis, it is a curd white discharge we all are familiar with. And bacterial vaginosis, it is a thin white homogeneous discharge externally on the posterior fourchette, and the cervix is usually normal in appearance. This is the spectrum of PICS, trichomoniasis in the first, then the bacterial vaginosis and the candidiasis on the bottom left. So coming to the trichomoniasis, we have seen it is more common in vaginal douching should not be done. Many a times the girls come that they are doing douching in routine. It actually erodes the flora and it should be prevented. So examination, it is strawberry cervix with the discharge. And how do we actually investigate? Motile flagellated trichomonas are visible on the wet saline smears, and the advanced testing is also available if needed. Metronidazole 2 gram single dose can be given for the treatment purpose, or metronidazole 500 milligram orally twice a day for 7 days in patients with HIV infection, or tinidazole can be used instead of metronidazole 2 gram orally single dose. Retesting within 3 months of the treatment in sexually active women is advisable, and the treatment of the partner is strongly recommended. In persistent or recurrent infection, it has to be differentiated from a reinfection by an untreated partner, which is common, and this has to be treated as a fresh case. So both the patient and the partner need to be treated with metronidazole 500 milligram twice a day for 7 days, or 2 gram OD for 7 days if the first one fails. If the second one also fails, she needs to be tested for resistance as it is indicated. Coming on to candidiasis, it is a curdy, thick discharge, causative organism by the Candida albicans and the fungal. In the uncomplicated vulvovaginal candidiasis, it is mild to moderate symptoms, and the diagnosis is by a KOH wet preparation. It gives budding yeast and hyphae formation if we see the slides. The complicated vulvovaginal candidiasis is the recurrent one. It causes severe symptoms, and the vaginal discharge culture is important. So how do we treat? We need to see the history, the direct smear. We do a whiff test, which is negative. The culture can be positive on the Sovrod's dextrose media, and we can give 1% clotrimazole cream or 2% miconazole cream for 7 days for local application. A pessary, a vaginal suppository, 100 milligram of clotrimazole for 7 days can be used, or a 200 milligram miconazole vaginal suppository for 3 days it can be used. If required, fluconazole 150 milligram orally single dose is sufficient. If needed, we can repeat a dose after 3 days. Nystatin 2 lakh units vaginal tablet inserted at night for 7 nights is for the recurrent cases. When do we say it is recurrent? It is defined as 3 or more episodes of symptomatic infection in 1 year. Vaginal cultures should be obtained from the patients to confirm the diagnosis, and the ointment is same as 1% clotrimazole and 2% miconazole, or a tablet of fluconazole 100, 150 or 200, 1 tablet every 3rd day for a total of 3 doses on day 1, 4 and 7. We have to explain the patient particularly from the days like Tuesday, Friday and Tuesday or something of that sort. So the bacterial vaginosis is the commonest cause of vaginitis. Many risk factors, including dishing, smoking, immunocompromised state, and the multiple partners. It has a foul-smelling odor, and if we see the Amsel's criteria, they are presence of clue cells. If you see on the left side, these are the bacteria which are on the cells, and it gives a clue to the diagnosis. So they are known as clue cells, the vaginal cells with the bacteria stuck on them. The Nugent scoring is done. It is a very simple test. Do a gram staining. In half an hour, you get the report. If it is 0 to 3, it is a normal. 4 to 6 is the intermediate score. And it needs a repeat test later. And if the score is 7 to 10, it is suggestive of bacterial vaginosis. So how do we treat that? The first line is secnidazole 2 grams orally of single dose, or metronidazole 2 grams orally single dose. Alternatively, we can give metronidazole 400 milligrams twice a day for 7 days, or clindamycin 300 milligram orally twice daily for 7 days. Routine treatment of sex partners is not recommended because it is actually the overgrowth of the normal vaginal flora, and alcohol consumption should be avoided. The recommended treatment options for vaginal discharge syndrome in cases of cervicitis, if it is by Neisseria gonorrhoeae, we give ceftriaxone injection 500 milligrams intramuscularly single dose, and the effective substitutes if we have to give an oral medication is cefixime 800 milligrams orally single dose. We are using this routinely and it is quite effective in these patients. Chlamydia trachomatis, we give doxycycline 100 milligram twice daily for 7 days, and effective substitutes in these cases is azithromycin 1 gram single dose, or erythromycin 500 milligram 4 times a day for 7 days, or ofloxacin 200 to 400 milligram orally twice a day for 7 days. So this is a very simple flowchart. I understand it is a busy slide, but a patient who comes with a vaginal discharge, see the history, perform a clinical examination, refer if any other condition is identified, do a per speculum if it is normal and it is high risk. If the patient is high risk, presumptive treatment for Neisseria gonorrhoeae, chlamydia trachomatis is required along with the screening for HIV and syphilis. If it is not high risk, just do the screening and the preventive services should be offered with a regular follow-up. Suppose there is evidence of vaginitis, treat accordingly along with the screening of HIV and syphilis. If there is evidence of cervicitis, treat accordingly. Follow up the patient after 1 week. Following up is very important. If the symptoms persist, evaluate for persistent cervicitis or vaginitis and manage accordingly. Still, if the symptoms persist, refer to the reference laboratories for etiological testing and manage and follow up as per results. Coming on to the lower abdominal pain, it can present as a PID. Patient might have fever, vaginal discharge, menstrual irregularities, dysmenorrhea, dyspareunia, any dysuria, lower backache for that matter. The causative organisms can be Neisseria gonorrhoeae, chlamydia trachomatis, and Mycoplasma hominis gardnerella, bacteria which are associated with bacterial vaginosis. We need to do a general examination, a per speculum, a per abdominal, and a pelvic examination. Look for any tenderness. The recommended treatment regime is same as we discussed in the previous section, but for anaerobic cover, we need to add metronidazole 400 milligram orally twice a day for 14 days. Doxycycline 100 milligram twice a day for 14 days should be preferred over azithromycin 1 gram dose for management of lower abdominal pain syndrome or PID. This is in recommendation by the NACO. And it also says the following regimen, which is the choice of treatment: cefixime single dose plus doxy for 14 days and metronidazole for 14 days. Suppose you see these wart-like structures, these papillary structures on the local examination. It is very painful and tender. Suspect herpes, which is treated with acyclovir 400 milligram orally 3 times a day for 7 days, or 200 milligram. If you are giving 400 milligram, you are supposed to give for 3 times a day. If you are giving a 200 milligram tablet, give it for 5 times a day for 7 days. Alternatively, if we want to reduce the duration of the medicine, we can even offer valacyclovir, which is available in 500 milligram dosage. Also, 1 gram is available once a day, but the recommendations by NACO, they say 500 twice a day for 7 days. Or famciclovir, 250 milligrams orally 3 times a day for 7 days. In cases of recurrence, the dose is increased. In the recurrent episodes of herpes, the acyclovir is given in the dosage of 800 milligram twice a day for 5 days. or 400 milligram thrice a day for 5 days, or 800 milligram 3 times a day for 2 days. Valacyclovir is a substitute given in the dosage of 500 milligram twice a day for 5 days, or famciclovir 250 milligram twice daily for 5 days. In recurrent episodes of herpes, suppressive therapy is given as 400 milligram of acyclovir twice daily, and valacyclovir 500 milligram once daily. An effective substitute as famciclovir 250 milligram twice daily. The dose is increased for the patients with HIV or immunocompromised patients. If we are suspecting syphilis, the patient has a chancre or the soft chancre or the lesion. The transmission is by the break in the skin or the mucous membrane. It has a partner transmission rate highest in the early stages within 1 year. So the primary syphilis, it presents as a painless ulcer. The secondary syphilis develops 6 weeks to 6 months after the primary lesion. And condyloma lata are highly infectious lesions seen in secondary syphilis, which are coarse, broad-based, soft, pink, tan, flat-topped, and moist lesions. This is the image of the condylomata. And in the latent syphilis, which is the third stage, it occurs 2 to 6 weeks after the infection with the Treponema pallidum. In the tertiary syphilis, which is a slowly progressive disease but rarely seen in this age group, so I'm not touching this the tertiary syphilis. How we diagnose these cases is the dark field examination with Uter treponemal's test, which is the point of care testing available for syphilis. So the VDRL, there are non-treponemal tests. The treponemal tests are TPHA, which are the specific tests, the FTA ABS fluorescent treponemal antibody absorption test, and also the agglutination tests. So the point of care test, which is the new rapid treponemal test, are used for the screening the syphilis. Even the reverse testing algorithm is available, and this can confirm the diagnosis. What is the disadvantages? Over treatment of the previously cured woman with persistent residual titers should not be done. So how do we treat? We treat with benzathine penicillin, which is given, always involve the dermatologist in these cases or the medicine physician. The benzathine penicillin is given in the dosage of 2.4 million units intramuscularly single dose, which is divided into 1.2 units in each buttock following a text dose. Alternatively, we can give doxycycline 100 milligram twice daily for 14 days, or erythromycin 500 milligram 4 times a day for 14 days, or ceftriaxone 1 to 2 gram per day intravenously or maybe intramuscularly for 10 to 14 days. It is titrated as per the treating physician. In the late syphilis, it is the benzathine penicillin 2.4 units again once weekly for 3 consecutive weeks, or alternatively doxycycline or procaine penicillin can be used. Suppose a patient has chancroid, a tablet of azithromycin 1 gram single dose is sufficient. Effective substitute is ceftriaxone 250 milligram single dose intramuscularly. If a patient has lymphogranuloma venereum, a doxycycline 100 milligram orally twice daily for 21 days suffices, or we give azithromycin 500 milligram 2 tablets once a week for 3 weeks. I understand it is quite extensive, but we can always refer to these guidelines. I can share the guidelines in the group after this talk. So the human papilloma virus, this discussion is incomplete without addressing the HPV, which is quite common. So prevention these days, we can give vaccinations which are readily available, the quadrivalent and even the nonavalent is available these days. So the 2-dose regime should be offered to age group 9 to 14. Even in India, they are coming up with single doses also sufficient to complete the coverage. 3 doses is required for age group more than 15 years, 0, 1 to 2 months and 6 months. So the girl might have warts which are caused by human papilloma virus. They can be single or multiple, and they have to be differentially diagnosed from the condyloma lata of syphilis or the molluscum contagiosum also. The treatment includes podophyllin 10 to 25% per vaginal, or imiquimod 5% cream. We can take a biopsy and send for histopathology to confirm this. Trichloroacetic acid 50 to 75% strength is used for treatment of the vaginal warts. For cervical warts, podophyllin is contraindicated. Biopsy of the warts should be taken to rule out a malignant change, and cryocauterization is the treatment of the choice. The last line was important actually. The cervical cytology should be periodically done in the sexual partners of men with genital warts. Surgical treatment of the warts includes cryotherapy, electrocautery, laser treatment, or the intralesional injection of interferon is also very effective. These are the lesions of molluscum contagiosum, which can be seen on the genital area or the abdominal or the it is a pox virus and it is treated in visual lesions. They usually regress without treatment in 9 to 12 months, but each lesion should be thoroughly opened with a fine needle or scalpel. Derma consult should be taken in these cases, and expedited partner therapy is required. A prescription is provided to the diagnosed patient for their partner. Both the patient and the partner needs to be treated. So this is the form which we are using in Safdarjung Hospital in the STD clinic. It includes all the details of the patient, examination, her past history, her abortion history, everything. The examination starting from the local examination, the mucosa, the oral, anal, and the eye, the lymph nodes, the cutaneous examination. We see for the specific diagnosis of all the sexually transmitted infections, any specific tests if they are required, if she has taken any previous history, whether we are treating the partner or not, and to what is the behavioral history of the patient, what is the partner history of the patient. This needs to be taken in detail. And then when was the first follow-up? How do we follow up secondly? And patient has to be on regular follow-up. To summarize, this is by the government. They distribute according to the kit, so it is easily we can easily prescribe. So kit 1, if we need to summarize, it is by the national body, the NACO. It is tablet azithromycin 1000 milligram and cefixime 800 milligram single dose for the urethral discharge syndrome, for the vaginal discharge syndrome, painful scrotal swelling, and presumptive treatment. The kit 2, which is green in color, it includes tablet secnidazole 2000 milligram and tablet fluconazole 150 milligram single dose. It is given for the vaginal discharge syndrome. Kit 3, which is white, it has benzathine penicillin injection and tablet azithromycin. A disposable syringe is available with sterile water. It is used for syphilis and chancroid, which comes under genital ulcer disease syndrome. Kit 4, which is blue in color, it has tablet doxycycline 100 milligram, 28 capsules, and azithromycin a single dose. It is given again for genital ulcer disease when unavailability or there is history to benzathine penicillin. Kit 5, which is red in color, it is given for genital ulcer disease syndrome for hepatic ulcers. It has acyclovir. Kit 6, which is for the lower abdominal pain or the PID, it has cefixime, metronidazole, and doxycycline. Kit 7, which is given for the inguinal bubo under the genital ulcer disease syndrome, LGB proctitis under the anorectal discharge syndrome, it has doxycycline in it, 42 capsule, as the treatment might need 21 days. And last but not the least, Kit 8, which includes tablet cefixime and tablet doxycycline for the anorectal discharge syndrome. I would request everyone to go through these guidelines. They have very nicely explained all the details on the STIs and the reproductive tract infections in all the sections across the adolescent, reproductive, and the special age groups. Thank you so much.